All right, so do you have questions for me before we start?
Okay.
This needs to be recorded by the host. So this is like an outline of just what we've gone over. So that might help.
Okay. Cool.
All right, so this is like EKG stuff, right? So you can see that. Let me zoom in a little bit. Let's zoom. Where's my zoom at? There it is. All right, so EKGs, all right? And let me know what you want to do. You know, EKGs, you want to do, you focus on GI or a little bit of little sprinkles of IV push.
What we're gonna need help on is the pacemakers.
Pacemakers?
Yeah.
We talk about pacers. So as far as like pacers and what you would do with pacers, and I'll share this document with you as well. All right, so pacers, you're going to be knowing down here, right? The different types. What are different types of pacers? You got TCP, transcutaneous pacers, first step, right? To come in and they are symptomatic. What does symptomatic look like? It's the song, right? So chest pain, shortness of breath, hypotension, confusion. So there could be also going to be alternative, right? So you, like I said in the chat, you can't just memorize things. You have to be able to know what the words mean. All right. So instead of chest pain, you might say substernal discomfort, or they have hypotension. It's a blood pressure less than what? 90. So they got a blood pressure of 84/42. That's hypo, and they got that really fast rhythm on the screen. Or they got a really slow rhythm. That's concerning, right? If it's outside of 60 to 100, technically, and they have hypotension, it could be related to arrhythmia, right? We're always going to treat the underlying cause. Maybe there's something else that's causing it. But where's I going with that? So yeah, so transcutaneous pacer is for someone that has chest pain or substernal discomfort, or they have discomfort in this place right here. It hurts right here, aki, right? So that's going to be that's chest pain, shortness of breath, right? So what else can tell you that someone's shortness of breath? Respiration rate's high, or their sats are low, the PO2 is low, low PO2. Less than 80, right? 80 to 100 is normal. And you have, and then like maybe they could be tripoding, they could be orthopnic, they could be all these things that release, they could be cyanotic, they can have all these things that are short of breath, right? And then what's the last thing? Chest pain, shortness of breath, hypotension, confusion, right? So their ANO times less than 4, right? They are confused, they don't know their name, right? These are things that would tell you that they're confused or like comatose even, right? Or they're unresponsive. Now, those are things that would clue you in that the rhythm is symptomatic, right? I mean, yes, it could be something else causing that. It could be just a severe infection, or it could be a severe stroke, but we're focused on the EKG stuff right now. But yes, if they're like that and they have a Brady rhythm on the monitor, they need to get a TCP. And then what's next? TVP, right? Transvenous pacemaker, right? And then what's after that? PPM, permanent pacemaker. That's if it didn't resolve, if you couldn't fix it. With a TCP, usually about 2 hours, and they're going to move on to a TVP, and you can have that for like 2 to 3 days sometimes. And then if it really doesn't resolve, you could get a permanent pacemaker. So why would someone need a TV? Why would it resolve? What's the reason why someone get super bradycardic and then it would resolve in like 2 to 3 days? Drugs, right? They overdose us in drugs, right? Or they could have had an MI and we fixed the MI. Right, but either way, they have drug overdose, right? And for your drug overdoses, I think I might put that in here as well. So what are your drug overdoses? How do you fix those? You can make it go away with glucagon, right? So beta blockers, and which other meds? Your calcium blockers, and it's all 3 of them, or all 2 of them, the diltiazem, and the dipines, right? That'll do it. I thought I had it on here, but let's put it somewhere under Brady rhythms, maybe. There it is. Thank God for Control F. All right, so ABCD meds. So glucagon for calcium blockers and beta blockers, and digoxin needs what? Digibind, right? So that would mean you probably need a reason for a pacemaker. Maybe hopefully that could work, but sometimes it doesn't, right? So they might have something else underlying, right? Age can cause AFib, but also can cause bradyarrhythmias, right? Your SA node just gives up. It's like, it's peace, I'm out, all right? Going to heaven. Right, so it's gone, right? And then now you have your AV node taking over, right? And what's your AV node rate? 40 to 60, right? So it could be just an AV node rate with maybe a little block, or it could be a junctional rhythm, right? And the AV node can peace out. It's like, you know what? SA node had a good thing. I have broken heart syndrome now. I'm peacing out, right? And now what's next? 20 to 40, right? You got idioventricular, right? And you need a pacemaker for that, right? So as far as pacers, back to pacers, TCP, right? We got, they need a permanent pacemaker. And like, what are some teaching for permanent pacemakers?
Or a sling
A sling for how long?
for a week.
Sling for a week?
No, day, I'm sorry.
Usually 24 hours, 48 hours tops. Are they gonna be checking their pulse for a week, right? They'd be making sure they're not getting bradycardic, right? We're gonna send them home and make sure they check their pulse. The pulse is 40 and the pacemaker set for 60. That's a problem, right? Or they just tell them buy an Apple Watch and I'm telling them pulse all the time, right? So what else? No wand, no gate, right? Make sure they get a medic alert card so they don't have to go through the wand or gate, right? MRI cards, that's a good SATA question as far as what's a teaching for a permanent pacemaker. And then complications that can happen. Why is their heart rate 40? What happened? Right? Identify, is it an FTP, an FTC, or an FTS? Is a failure to what? Pace, right? What does a failure to pace look like?
There's no taster mark.
There's no pace or spikes, right? Failure to pace is not pacing, right? And when something's pacing, there's pace or spikes on the EKG strip, right? So that's almost the easiest one, right? The patient has a pacemaker and I have a strip and there's no pace or spikes. That's a problem, right? That's failure to pace, right? So that's the easiest one. As far as failure to capture and failure to sense, as far as capture, I think it's capture attention, right? Failure to capture the attention of the ventricle to make it do something, right? So failure to capture means you see a pacer spike, but nothing happens after it, right? So they're like a P wave and a pacer spike and then nothing, right? Like they're V-paced. A P wave, pacer spike, no QRS. It's like where to go, right? It was unable to capture that QRS complex or capture that ventricle to depolarize and create a QRS complex, right? And that could be due to a low battery, right? It wasn't enough MAs, not enough milliamperage to depolarize that ventricle in the first place. Or it could be due to it's not even touching the ventricle, right? So it's just floating inside the right ventricle. It's just floating there. It's not even touching the myocardium. And it's trying to send the signal, but it's not reaching the ventricle to depolarize it, right? And then the last one is failure to sense, right? So failure to sense is what? What do you see with failure to sense?
Taster spikes and random.
You see pacer spikes for sure, right? You see pacer spikes with failure to sense, failure to capture, but you're going to see abnormal. It's all over the place, right? It might cause some depolarization here and there, but it's basically spiking where it should not be spiking, right? It's not sensing the normal intrinsic rate of the patient, so it's all over the place. And the risk with that is if it paces on where, could cause some lethal rhythm. Yeah, it can go on the R on T and cause fires in the T wave right here, right? That could cause some problems. And what's that? Torsades, right? It's a polymorphic ventricular tachycardia, right? That's one of our causes of torsades. All right, so let's look up torsades again. I think I have it somewhere else. There it is. All right, so it's one of your lethal ventricular rhythms. So guaranteed to PCL a lethal rhythm on the test, all right? Guaranteed, and probably final as well because you need to know lethal rhythms. You need to recognize that. Like if it goes on the monitor and you're like, oh, that's nothing, right? We want you to be able to recognize that is, you guys get some tighten cheeks, like, oh, that is wrong, right? So when I recognize that as a bad thing. So R on T is a cause, right? We got R on T there. We got, what is a prolonged QT? What does a prolonged QT look like? More than 0.45, more than 0.50. You're very, very cautious. Yesterday, the QTC was 0.66. And the nurse is like, no, move aside. Let me show you how to measure QT. And she did it right between on the top of the T wave, right? He's like, look, say it's 0.46, it's fine, right? No, it's 0.6, 0.66 is really bad, right? So when I recognize that is a problem, right? And we shouldn't give the medications that prolong the QT. What are some medications that prolong QT? So amio is a good one. Prolonging drugs. Amio, what else? Antibiotics, right? Especially your fluoroquinolones. That's usually why fluoroquinolones are not recommended in the hospital setting and on the tele floor in the ICU because you're at high risk for prolonged QTs. What else?
Do fluoroquinolones like start with a certain
They all end in fluoxetine, levofloxacin, moxifloxacin.
because I have a feeling it's gonna be like, oh no, you should have an
Antipsychotics.
Antipsychotics, very good. So you got some anti-psych meds, especially like Haldol. Or haloperidol is the brand name because according to the test policy, you're not supposed to put brand names. So haloperidol. What else? Those are the kind of big ones, right? So you recognize, so you can't just, you're not gonna be looking for the answer on the test for prolonged QT. You gotta know what prolonged QT is, right? A knowledge-based question is just saying, can I memorize these facts and regurgitate them on the test, right? That's intellectual vomiting, right? So that's not what we want. We want you to understand what that looks like in real life. So you go to real life and you measure QT and it's 0.66. That should, fire off some bells and say, oh, that's prolonged QT. They're at risk for, what's that word? I know it's French, right? So that's a risk for lethal rhythms. So we want to make sure that's the NCLEX wants to test you as well to make sure that you are a safe nurse, that you recognize that that's a problem, right? All right, so back to torsades. You got prolonged QT, you got RNT. Lights, what kind of lights? We got low lights, right? So low mag is usually first on the list, low K, right? So it's not, again, the test is not gonna say which one following the causes of torsades. It's not gonna say low mag, low K. You have to recognize that it's a low mag or low K. All right, that's an application question, analysis question. That's a critical thinking question, of which the test is how much percentage? Like 85% is where it's supposed to be in third semester, right? 50% will be knowledge-based, whereas identify this rhythm, right? Identify this, identify, right? Regurgitate this for me, right? That's 15% of the test. That's not a passing score, unfortunately. So 85% is where you have to interpret the information and understand it, right? So low K, low mag. So again, what's a low K, low mag? In case we didn't know, there's some chat over here. Hold on. What's low K, low mag? So yeah, you want to know some symptoms, but low K, low mag don't have too many symptoms. Low mags can have DTRs that are elevated, or not elevated, but are over responsive, right? But what about a value? Because those are the ones we're really going to see for mag and K. As long as it's less than 1.8, 1.8 to 2.5, that's usually why I remember. And if it's less than that, and I'm not going to say it's 1.72. What do you think? Right? No, it's going to be obvious 1.2 or 0.9, right? And the mag will be, the K will be obviously low. What's an obviously low value?
2.9.
Yeah, that's obviously low. Yes.
For the exam, you ask a question, what the values or the symptoms?
Mostly the values for mag and K. I mean, symptoms are going to be very generalized, right? They're going to have leg cramping, cool, right? So it's not going to be very, very specific. It'll be obvious, like they have, maybe they have, they have a K of 2.2 and they have all this activity, right? That's a sign of low potassium, right?
Are there gonna be the normal values on there?
Normal values won't be there. No. So as far as if someone's already made a lab cheat sheet, so that's what that folder is for exam one study tools. You can load all your cheat sheets in that folder. You know what I'm talking about? So where's it at? It's maybe over here. Sorry, McKenna, I'm showing our chat history. Let's go over to, where's my drive at? Lecture content. We got PowerPoints for you guys. And here, exam one study tools. So you can drop all your stuff in there, right? Someone just busted some rhymes this morning. You can drop those rhymes in there, right? As far as little cheat sheets and stuff. And I'll drop this one in there as well, okay? And drop your other things. If you do like all the labs for test one, right? So you just go through for EKG labs are your lights, obviously. Right? And what happens if your K is low, your K is high, your mag is low, your mag is high. But you're talking about the high mag, but your calcium being too high or too low. Sodium we're not worried about sodium with EKGs. All right, so just drop it in there. So we have all of our tools to help us be successful. Okay. And then we go on to like GI stuff. What are your GI labs you have to know? Right. All right. So this is your time. So let me know. I'll keep talking. I can talk for 6 hours. Let me know what you want to go over. All right. Is that good for pacemakers as far as what you should know for pacemakers? All right. Where do you want to go next? We kind of naturally went into lethal rhythms. Where do you want to go next? Shockable rhythms. So these are lethal rhythms that are shockable. You can shock somebody that has a pulse, right? When would you shock someone that has a pulse? When they are symptomatic, right? They are symptomatic and they need to be shocked out of that rhythm, right? So they have usually to be a fast rhythm, right? They have a fast rhythm and a pulse. You're going to shock them, but how are we going to shock them? In a controlled, synchronized way, right? So somebody saw a synchronized cardioversion yesterday, right? So what do they do beforehand?
Synchronize.
It's the sync button before the patient even arrives to the suite. What do? Educate, and you're gonna, what'd you say? Put to sleep, okay, before you, okay, so before you put someone to sleep, what should you get? Consent, right? That is bad form, all right? So make sure you consent before you put someone to sleep or, rock their body with a shock. Okay, so you're gonna get consent, all right? We're gonna give them sedation, all right? So they don't forget it. And then we're going to hit the sync button, right, when we're ready, and then we're going to shock them, right? And the way the machine works is when you shock them, worst case scenario, they could go into lethal rhythm, right? So you always have to hit sync every single time. Every single time the doctor says, oh, we shock them again. And if there's just a shock, that can just shock right on the T, right? And cause what lethal rhythm? Torsades, right? So that's shocking. Rhythms with a pulse, right? So rhythms with a pulse could be anything that's fast that has a pulse. That's it, right? You could even shock sinus tachycardia, right? Sometimes patients can't tolerate it, but we're always trying to fix the underlying cause. That's always the goal in all of this before we have to shock them, right? They're like sinus tachycardia once 140, and they're like really, really working. They're really short of breath, hypotensive. Then we can treat them like God. Maybe it's just pain. Maybe it's just a fever. Maybe fever control. Maybe it's what else? What else causes your SNS to fire?
Exercise.
They're probably not exercising at that point, but yes, exercise can cause tachycardia, stress, right? Just the infection, the fever. I think I put that here. All right, drugs, right? They partook in some methamphetamines, right? Meth, drugs, etc. All right. We got low blood sugar. The sugar just could be low, and let's fix the sugar. Maybe that will get them out of that tachycardia, right? Can't say, oh, the sugar's low, and you come in with a crash cart. So I gotta know how to fix this, right? So we're gonna go ahead and shock them first, or sorry, shock them first. We're gonna go ahead and shock them with some glucose first, and if they have a low sugar, right? And then if that doesn't work and it's still sustained, all right, they have some kind of weird, not biology, but it's like scar tissue that put them into like a fast rhythm. We can shock them if they have a pulse, right? And we shock them with synchronized cardioversion. All right, so that's synchronized cardioversion. It's everything up into the first lethal rhythm. What's that lethal rhythm that could also be shocked? It's like the dividing point is which kind of VTAC? It's good. It's monomorphic VTAC with a pulse, right? Polymorphic VTAC is not going to stay. What did I do? Monomorphic VTAC is not going to stay. What I'm trying to say, polymorphic VTAC is not going to stay with a pulse for very long. That has to be shocked immediately or fix the underlying problem immediately. Get the MAG or do whatever you need to do to fix that torsades. But shocking early is what you definitely, if someone goes in torsades, you're grabbing the crash cart with the defibrillator on it to shock them out of the rhythm. Let's go back to VTAC here. There we go. Nope. All right, so VTAC with a pulse versus without a pulse. So which one gets synchronized cardioversion? With the pulse is synchronized. Unsynchronized, aka defibrillation. And we defibrillate everything below that up until what point? You say PA-ness? All right, so let's highlight this. We're going to be shocking this stuff right here, right? Let's change the color, highlight color. Ooh, got more options than Microsoft Word. Microsoft Word has like eight options. All right, let's do purple. All right, so these are guys we're going to defibrillate. All right, defib up to this point. That's called unsynchronized or synchronized. Unsynchronized cardioversion. All right. Whereas VTAC with a pulse and everything above that, we can, or not the Brady rhythms, but every tachyrhythm, you can shock with a pulse if it's what kind of cardioversion? Synchronized cardioversion. All right. Do we shock PEA systole? No, right? And if it's PEA, it's going to say what on it? Somewhere in the stem or on the EKG itself, it's going to say no pulse with this rhythm, right? In some fashion or other, right? The nurse assessed pulse and was unable to find one, right? The nurse, there is no pulse noted, right? And that's PEA and systole. So part of the game for MedSurg 1 was recognizing the rhythms, just identifying them. And now you have to, I guess, identify them and know what's the treatment causes and management of those things are. As far as like nursing management, it's pretty much one of two things. What are they? We're doing, well, as far as like rhythms of the pulse, you're doing ABCs, right? You're doing ABCs, and C is your circulation, right? Airway breathing circulation. So get some oxygen on them if oxygen is low. and check their circulation, right? Yeah, you could be checking cap refill, right? But no, we want to know what the blood pressure is, right? Because the blood pressure is low, we got to intervene, right? We can intervene with meds sometimes as long as the blood pressure is good, right? Because most of the meds are going to be low in your blood pressure if they're fast rhythms. All right, so then you got ABCs, and then once you have a rhythm that has no pulse, I thought I had CABs somewhere. Let's look CABs. Yeah, CAB interventions. That's for lethal rhythms, right? Lethal rhythms, we're going to be doing circulation first. And how do we fix someone's circulation if they have no pulse? That's CPR, right? So lethal rhythms, you're going to be doing. You're always looking for H's and T's, but the interventions are CABs, right? And which rhythms get CABs? Lethal rhythms, right? So the lethal rhythms, no pulse, right? And like in other words, right? It's not even an example of. In other words, they have no pulse, right? You're doing CABs. You're doing circulation first. You're doing CPR, and you should be hit the code button first. Otherwise, you're doing CPR for 2 minutes. You're like, man, I'm feeling lonely, right? I should get some help in here. Right, so that's why I always hit the code button first.
That would be like torsades and P.
Mhm.
Yeah.
Yes, so torsades, PEA, asystole, VTAC, all the varieties without a pulse, right? Whether it be polymorphic or monomorphic. All right, so it's been about 25 minutes on EKG. Are you good in EKG? Do you want to go move on?
Yeah, we're good.
All right, so what's next? IV push. Do you want a little sprinkle of IV push? So IV push meds you have to know are the ones that you use for EKG and GI. Those are the ones we want to see, right? So if they have, what are those meds that we had that kind of overlap? Metoclopramide is on there, right? So you put down here meds. All right, so metoclopramide is on there, right? What disease process is that for? Metoclopramide.
Oh, the Panto or
Well, that's pantoprazole, but what do we use metoclopramide for in the GI section?
all for GERD and BG.
Yeah, so if they have a problem with movement of the GI, the contents of the GI, we can give those meds. Okay, so pantoprazole was on that list, right? There's probably some H2RAs on there somewhere, right? What are your H2RAs? What are some examples of H2RAs? They end in tadine, right? So cimetidine, ranitidine, right? So pantoprazole, so we're just looking for meds that overlap. Yes, you give atropine IV push, but you give adenosine. That was kind of talked about in the EKG section, right? Adenosine, atropine, right, or EKG meds. So to group them into like GI meds, right? And cardiac meds. Right, adenosine, atropine, epinephrine, etc. Right? So you have to know what they're indicated for, and they can be given IV push. Other cardiac meds, we give like digoxin IV push, right? And if we give too much digoxin IV push, it could cause what symptoms? Mhm.
Not the wrong.
Okay, yellow halos, and we want to know the reason for what happened. Nausea, diarrhea, and then how do we fix that?
Reversal.
Mm-hmm. You're going to fix it with Digibind. Digoxin Immune Fab is the brand name. Fabulous.
What do we have to know, like how quickly we push this?
No, that's no, you don't.
Okay.
And someone's dead, meaning they have no pulse, you can push as fast as you want. They're not going to make them any more dead, right? But if someone has a pulse, you have to push things slowly, right? Like especially like calcium, right? So calcium chloride, for instance. Calcium gluconate, right? You got to push those things slowly, otherwise you're going to cause a hypercalcemia. Hypercalcemia causes bradycardia, right? And someone who's hyperkalemic, which is the reason why you gave the calcium, right? That's one of our treatments for hyperkalemia. If someone's bradycardic from hyperkalemia and you give them a whole bunch of push of calcium, you're just going to put them into no pulse, right? You're going to braid them down to nothing or to PEA. So you got to give those guys slow, right? And other meds you can push fast, and that can cause what? Nope. Well, it can, some meds especially, but cause speed shock, right? That's just an allergic response to the medication. Like the immune system's like, whoa, what the heck is going on here? What is all this medication? Right? You gotta bring it in slow. Right? So what are your symptoms? So SATA for symptoms, what are the symptoms of speed shock? We get flushing, you just get a widespread vasodilation, right? Such as flushing, headache, right? And they get a surge response. And we'll talk more about SIRS on Monday lecture, but we've been kind of introducing it. It's just a widespread inflammation. So you get a widespread vasodilation right there. And we get some, they're not going to feel good at all, right? So I want to recognize speed shock can happen. And people ask me, well, what if they, I see all the nurses give it like, they just push it in, right? Why is nobody getting speed shock, right? Because there's certain medications like the calcium, right? Or in the math homework, which I didn't post yet, but in the math homework is one where if you give it too fast, that can cause some speed shock, right? Actually, no, we did the calcium one already. So yes, you want to make sure you give it slow. Okay. All right. Is that good for IV push as far as what you have to know? You want to know the complications, right? Complications of speed shock, the processes, right? Doing push, pinch, pause, pinch, push, pause for pushing it, right? Pushing it in, and you push it slow. And with the flushing afterwards, you got to make sure the flush is the same, the same speed, right? You'll see nurses give it really, really slow. They'll give that methylprednisolone over 5 minutes into the IV tubing, which is 2 cc's. They're giving half cc over 5 minutes, right? And it's like you just put it in the IV tube. That's all you did is push it really slow in the IV tube. It didn't even reach the patient yet. And then you go ahead and slam that flush in there, right? So the flushing did at the same rate, right? And in the meantime, you got to make sure your line is good, right? You're getting rid of the dingleberries, right? Because although platelets and everything are kind of attached to the inside of the catheters, you want to dislodge those. And how you dislodge them, right? Yeah, if you just push it, it's like a cool breeze for the dingleberries, right? So you want to make sure you're push pausing and breaking them apart. Okay, just like a bidet. All right, anything else as far as IV push? All right, so do you want to do tubes or organs? Tubes. All right. So as far as tubes, all right, we talked about the esophagus, we talked about the stomach, right? Esophagus, stomach, talk about the intestines, right? And there's our diseases for the tubes, right? There's a lot of diet mixed in here, so you should probably make a table just for diet, or the different diets for each one. High fiber is always recommended. There's not a low fiber diet in sight, right? Always high fiber, always losing weight, right? Best you can. And what else is there? What are some other diet things? I just kind of navigated diet. You want to talk about diet or no?
I have one question.
Yes.
About that. So the bottom half, your lecture, your slide says or cherries, avoid cherries.
Mhm.
But on the picture you provided us, it said cherries is low FODMAP. So which one would you want to see?
So the one that's on the table. So I might have just misread it, but
Okay.
there won't be a cherry question on the test. All right, but for FODMAPs, you want to recognize a meal that is appropriate for a FODMAP, right? So as long as the majority of the meal is good, that's fine, right? So like had the picture of the salad. I was just thinking of salad. You guys zeroed on the dressing, but that dressing must be high in vinegar, right? So I don't know, it could be a honey dressing. I don't know what it was. All right, so yeah, I wouldn't. Maybe I'll crop it out next time. Yeah. Just put a salad. All right. So yeah, so as long as the majority, because you can't be perfect with IBS diets, right? You want to get low for FODMAP, but I'll probably choosing, I'll make a menu selection of low FODMAP and high FODMAP, right? Going to make sure that it's not gas forming, make sure it's not dairy, right? As dairy and gas forming, it's automatically off the list. It's automatically wrong. Okay. So that's kind of diet stuff, right? High fiber, right? And then as far as the tubes and also the rocks, what else you're going to have? Low salt for some of your organ complications, right? Which organ complication needs low salt? Kidneys was not on this test. Well, a little bit of the kidneys with hepatorenal, but liver failure, right? Specifically when they have ascites, we want to make sure they're a low salt diet. Because if you're a high salt diet, you're going to start retaining more water. And that's just going to make its way to the portal circulation. And that's going to leak out and cause more ascites. All right, so back to the tubes. As far as you want to kind of make a table with the GI stuff, I think I did some diet here. Going back a little bit. So high fiber diet, food teaching, right? So a big thing with food teaching is like low LES stuff, right? versus high LES. I think I had a section up at top with LES. Examples. I guess not. All right, so yeah. So low LES versus high LES, right? So what's something that causes your LES to weaken? So you got meds, right? You have meds that can relax the sphincter, the lower esophageal sphincter, and we got diet, right? And I would consider a cigarette part of the diet. Some people would consider alcohol part of the diet, but alcohol and nicotine both do what? They relax the lower esophageal sphincter and worsen GERD symptoms, right? They also worsen PUD. They're inflammatory. Okay, but talk about the LES, they're going to weaken it, right? And as far as other foods, what other foods are there? Right, we got mints, we got nicotine, alcohol, fatty, right? Not spicy, but I'm not going to be testing on controversial things. Like, it's not controversial about spicy. It's not controversial about bowel rest being not good anymore for pancreatitis, but I'm not going to test you on that, right? Because everybody hasn't agreed just yet. So once everybody agrees, then I'll start testing students on it. But I'll just let you know that that's not the right answer to bowel rest currently. Yeah, bowel rest is like NPO and let them rest, right? And avoid morphine. That's totally off. You can give morphine, it's perfectly fine. All right. So anyways, low LES mints, you want to know those foods, right? What's relaxed in the sphincter? Any question?
Is there only going to be questions on foods that relax the LES or foods that?
It's easier to test on things that are going to cause a disease than what doesn't. I mean, you can, there'd probably be like a question like, here's my food diary. What do you think? Right. And then they say, oh, yeah, this is good, that's good, that's good, right? Or this isn't going to be causing complications. This is going to be causing complications. So really, you only have to memorize one of them, right? Or not memorize, but identify one of them, right? Because that's going to say, oh, I know that's bad, right? It's good to recognize bad things and the good things, right? All right, does that make sense for diet? If someone makes a diet table, upload it to the folder so you know all the diet things that you should know that you've kind of picked in your study, picked part in your studies. All right, so back to the tube. So we got the esophagus, right? We got our esophagus disorders. We got hiatal hernia, which kind of overlaps with GERD. So it's probably a good idea to know the difference between HH and GERD, or hiatal hernia and GERD, hiatal hernia and GERD. Okay, so what else? I think I had it on here somewhere. Where's my, with GERD, it can lead to what? Well, first, it's gonna take a pit stop at Barrett's esophagus, right? Is Barrett's esophagus cancerous? No, it's precancerous. It has cellular changes, but it's not quite cancerous yet. By the way, it can lead to, it's a risk factor for getting esophageal cancer. So if they have Barrett's esophagus and they have alarm symptoms, which you need to identify, that's a good SATA question, right? Like what's going to tell me I have alarm symptoms? I am at risk for, I should get checked out for esophageal cancer. So as far as like screening, like how do you even, or diagnostic tests you would do to see if someone has esophageal cancer? There's no lab values like with gastric and liver cancer, right? So EGD. So EGD is going to be a great thing to look at. And someone has Barrett's esophagus, they're getting like they're looking at that very frequently. How frequently they're not going to test you on, that's more advanced. But colonoscopy, yes, I want you to know how often you do colonoscopies for colon cancer. But they have alarm symptoms, no matter what, you're going to be checking to see if something's up. All right, so GERD, knowing different types of different kinds of pains, right? Because everybody comes in, I got chest pain. It's like, tell me about your chest pain, right? It hurts on my lower right quadrant. Your abdomen? Yeah, my abdomen. So that's not chest pain. You're a little bit off, right? But what causes left lower quadrant pain in the abdomen? You're thinking of diverticulitis, ulcerative colitis, right? That's usually where that's taken up shop, right? But what if they have upper abdominal pain? Like they say, oh, I got chest pain. It's like, it's right here underneath your sternum. Yes, underneath my sternum. So that's not chest pain, right? So what is that called? So the mid epigastrum, right? And it's likely going to be what disease process? Could be GERD, right? Could be peptic ulcer disease. It could be pancreatitis, right? And pancreatitis can even go into the left upper quadrant, right? So like I said in class, a good test question is looking to see, a picture of the abdomen with 9 quadrants, right? And point to where you're going to see diverticulitis, point to see where you're going to have Crohn's disease, right? Point to where you're going to have, pancreatitis, et cetera. Right? And the right option would be the correct option, not the right option. The correct option would be the mid upper gastrum or left upper quadrant of the abdomen. Okay, you know what I'm talking about, right? So abdominal quadrants. We got, there we go. Right, so you can this guy right here. So let's copy this one, get a better one. Copy image. Let's put it over here. All right, do you know where? Okay. So you got to point to the right spot. Where is this disease process at? And as far as symptoms, there are a lot of symptoms. You want to be able to, not gonna give you just like 1 symptom or 2 symptoms. You're probably like 3 or 4 symptoms and identify the disease process, right? So you learned about jaundice, you learned about flu-like symptoms, you learned about SNS a little bit, right? But that's not really a specific disease process. Just I'm hurt, I have stress, I have an infection, I have a disease process. But like liver cirrhosis is a good one, right? It's like, are these liver cirrhosis symptoms? Yes, they are, right? Identify them from the lineup, right? Is this pancreatitis or cirrhosis? Is this gallbladder or cirrhosis, right? Cirrhosis has a lot of symptoms. So I'm not going to test you like on Terry's nails. I cut my nails last night too. Forgot to cut my nails. All right, but yeah, Terry's nails or was it DP has like it needs a biovalve. The pituitary contracture, right? But anyways, it can be obvious ones, right? That are like signs of portal hypertension or signs of bleeding. Okay, and we're talking about bleeding. You want to talk about what's upper GI versus lower GI bleed. You can recognize what those look like if that's upper or lower. Okay, it's a good SATA question. Like which one of these can be an upper GI bleed? And that's all of them, right? With upper GI bleed, because it can be a fast upper GI bleed or a slow upper GI bleed. It's going to cause all the symptoms. It's going to cause what? Give me some upper GI symptoms. So we got some hematemesis, we got some coffee ground emesis, right? You got bright red blood to rectum, otherwise known as hematochezia, right? Or what's the other one? The pretty name of melena, right? So melena can also be a sign of upper GI, whereas lower GI, you cannot have coffee ground emesis for lower GI bleed, right? I have to say it because I've been asked. So no, it's not. I gotta explain. That's 20 feet of bowel. It has to go all the way up to come out, right? That doesn't say with like ileus that could cause some. And it's not coffee ground anymore. That's not coffee ground. That is stool that you're throwing up. Sorry. All right. So where else do you want to go? This is your time. I can go off and get on tangents.
I don't know.
We're confused on Hep B when it comes to
Mhm.
antibody, antigen. So they wanted us to know the difference between chronic, acute, active.
Yeah, so for Hep B, the surface antigen is or antibody is what you want to be zero in on. That's going to tell you if you have an active infection or you have immunity, right? So that's usually when you're going to zero in on. The envelope is another layer, literally, and I'm not going to really focus on that as much. But I want you to know that that's the surface one I want to pay attention to. All right, it's probably going to be the right answer, and then also whether it's DNA or RNA load, right? So which one's Hep B? Is it DNA or RNA? That's DNA, right? Everything else is RNA. And when you have a high viral load, that means the virus is there, right? And then we got to see the virus is there, and is this because they have a chronic infection or an acute infection? And when they have an acute infection, they're not going to have the antibodies yet, right? But yeah, I'm going to be testing on is the load there or not, and is it DNA or RNA, and then also is it the surface antibody or not? That's what you want to look to see if they are at risk, right? And talking about hepatitis is you want to know the risk factors and interventions, right? Because you don't get hepatitis just by existing. You have to have it done to you, right? So differentiating ABC labs, right? And as far as I thought I had it here, like teaching on the causes, right? Well, your versus like the I'm trying to say blood versus secretions, Okay. They could be anal secretions, or they could be semen, they could be sputum. These are all things like where our A, B, and C can come through. All right. And D just is attached to B. All right. So what else do you want to dig into? So we kind of stopped off at esophagus. Do you want to go back up there? So you got hiatal hernia. There's a difference, right? The difference between hiatal hernia and GERD, right? Hiatal hernia person has a lot of dyspnea, a lot of vomiting, right? A lot of undigested food, right? They're fun at parties. They bring their spittoon, right? Right, and they need to go and buy a new Nissan, right? Laparoscopic Nissan, right? They have to know the teaching afterwards with some teaching afterwards. So no air, soft diet. Make sure they're recognizing those teachings. They're adherent to those. All right, so GERD, esophageal cancer, and we got our stomach stuff, right? We got PUD and stomach cancer, right? And then a stomach cancer and colon cancer are going to have the alarm symptoms, but they're not going to have like the adenophagia and dysphagia, because that's the esophagus and a tumor messing up with that. But they're definitely going to have the what other alarm symptoms? Some weight loss. So unintentional weight loss is a trigger word, right? It's like, oh shoot, that's cancer. No matter what, where's the cancer answer, right? So the unintentional weight loss and all stuff is in the GI tract. They can start to become what? Anemic due to bleeding, right? So they have unintentional weight loss and they have anemia, right? And we'll talk about anemia for exam 2, but you can, you kind of carry over from what you learned from MedSurg 1 with anemia, right? And also you learned it in OB as well, right? With lead and such. Anyways, you get pale skin, you get fatigued, right? And of course their hemoglobin be low. I'm not gonna test you on hemoglobin, that's gonna be for the next test. All right. So that's PUD and stomach cancer. PUD, when no gastric versus duodenal. That's an easy guaranteed test question. Right. I say guarantee with an asterisk because I'm still combining all the test questions. I wish I could test you on every single topic, but I can't. All right. So that's every nursing program ever is I study all this material and you only test me on like one question from each one. But I do try to test from every different topic at least. All right. Because like hepatitis, I probably have like 2 questions I can ask, right? If I'm making it divided evenly. I could make it unfair and to test all on hepatitis for liver, but that's not fair. I try to make it a test question from everything. So you do have to know everything. That is the right answer sometimes you hear. Just study everything, you'll be fine, right? But I'm gonna test you on something from each little subject, each little topic at least. I'll try at least, right? What else? So PUD, right? Stomach cancer, knowing the differences, right? Alarm symptoms are symptoms of stomach cancer discovered early or late. Good outcomes or bad outcomes? It's a bad outcomes. What other cancer from the tubes or the rocks causes bad outcomes? Pancreatic cancer is probably the worst, right? And then stomach cancer might be second place, right? Which has the best outcomes? Colon cancer. You can discover it early. It takes 10 years to grow a polyp. It's like, I worked hard for that. And just snip, right? All right, unless it becomes invasive and it starts invading the bowel, right? And that's gonna start causing abdominal pain and might cause weird looking poops, right? They look like little snake poops. It's like, how'd you make that shape, right? Let me show you, right? So it's gonna be because the tumor is there compressing and causing these weird shapes and they start getting anemic, right? And they have the alarms such as a fatigue and paleness and unintentional weight loss, right? You good with stomach? All right. We talked about the meds a little bit. All right. And then intestines. You got hernias, right? With any disease process, you want to know the life-threatening complication. There's life-threatening complications with this previous section. With life-threatening complication up above with gastric. No, gastric is life-ending, but it's not life-threatening. Was like they're going to die. If they get that complication, they're going to die in the next 4 to 6 hours unless they get help that the nurse should recognize when they come into the ER or they come in, or they're just sitting there on MedSurg 2 and they're just, you know what? Oh, I got these symptoms. And you're like, oh, just, don't worry about it. You're fine, right? That's never the right answer. But it's like, let me sit down with you, just guided imagery, right? No, that's not gonna be the right answer.
That's always good.
It's good if as long as it's not life-threatening. All right,
What's the
so
question again?
life-threatening PUD complication.
Oh, bleeding?
Bleeding is life-threatening and perforation is life-threatening. Right? So life-threatening. So PUD, bleeding, right? And perforation. Right, so that's, you want to know life-threatening. Usually I try to highlight it in red, right? Try to use my colors, right? To highlight in red that is a life-threatening complication. So what's your life-threatening perforation symptom? They got peritonitis, right? Which can cause SIRS, right? They're tachycardic tachypnic, they got AFib RVR, right? And they have what else? Diffuse abdominal pain, right? And usually they got like guarding, right? And then like you do some diagnostic tests, you can see some free air, right? On the X-ray or CT, whatever, what have you. So as far as perforation, we got PUD causes, right? What else causes this? What other disease process we talked about could cause your tubes to perforate? Diverticulitis. Diverticulitis can perforate. What else? Hernia is not going to cause perforation. It can cause strangulation and gangrene. It's going to just wither away. Cholecystitis? No. The gallbladder can pop, but yeah, did I put that on there? That's a little more rare. That's the more common ones. Crohn's can do it. You're like, why not ulcerative colitis? Because it only hits the first layer, first mucosal layer, right? But it can't hit the first mucosal layer and start forming fistulas with anus. So that's on the table. But as far as like perforating the actual bowel, those guys are definitely going to do it, right? Top three. A fistula can just be like they're like married, right? So it sees the bladder across the way, like, what's up, babe? And it's gonna go over there and it's just gonna form a fistula, right? It doesn't actually, and it's gonna just go between each other. But that's a wrong image, right? So it's gonna be, they're perforated now, right? They're now married, right?
Yeah, I was about to be who will be your MVP if you have
MVP? I'd have to look it up as far as like actual, but like
like you just as an expert.
that you see, I'm not the MedSurg expert. And what you see is going to be a diverticulitis, or that could be on. Diverticulitis is like, as far as the like complications, right? I mean, diverticulitis is not as common. That's why when you call a GI surgeon in the middle of the night, they're like, oh, they just have diverticulitis, right? They can fix it with antibiotics, hopefully, right? But that can cause it. But really, like PUD, they'll come in. That's really the one I see the most common. All right, what else? Are we good with we got distracted? All right, so intestines, you got hernias, right? These are, I was kind of talking about life-threatening, right? Because those are life-threatening versions of hernias, right? What's incarcerated versus strangulated, right? So any one of those two words is concerning. Which one's more concerning?
Strangulated.
That has a lot more connotation than incarcerated, right? Like he went to jail. He went to jail and got strangled. Oh shoot, that is bad, right? All right, sorry, I got some chat people here. All right, so yeah, so hernias, IBD, inflammatory bowel disease. What's the difference between Crohn's versus ulcerative colitis, right? Look at the difference. They both have extra intestinal symptoms. But like one goes through multiple layers. One has fistula, or sorry, perforation risk and fistula. One has like kidney stones, one doesn't. Right, but they all have very similar symptoms, and like their meds, like which they're for pain and inflammation. Recognizing those meds are for IBD. IBS, we kind of talked about FODMAP already, right? And it's gonna be like identify the correct meal, ID correct meal. And IBS meds, we have like, again, you can do like a whole chart just for meds for exam one. Order my meds out the no, right? And just make it separate to GI meds and cardiac meds. So like lubiprostone, it's like, well, that's IBS med, right? That's not an IBD med. IBD meds should have something to do with fixing pain, inflammation. But also pain inflammation can be for our hemorrhoids too. What else? Do you still want to keep going with these guys?
I think we're good.
Okay, so general things, right? High fiber diet, mentioned food teaching, cancer diet teaching, right? Because we know that gastric cancer is caused by salty stuff, right? And nitrosamines. And what are nitrosamines? Foods that are smoked usually, right? Yep, jerky. It's like I bought a new smoker. Oh, I'll see you. That's your gastric cancer risk now, right? All right. So what causes perforation symptoms? Who gets peritonitis? Kind of mentioned that above. Risk for bleeding. Who's at risk for bleed? We talked about who's at risk for perforation. Who's at risk for bleeding? So there's ullosis versus litis, right? So that's a good, easy static question, right? Who's going to be at risk for this, right? All right. Patient present. The nurse preceptor is asking the student nurse who's at risk for bleeding, right? That's the easy way to verbalize that, right? And you would select those guys, right? You got GERD, IBD or IBS causes bleeding. IBD, inflammatory bowel disease. It's inflammatory down to the blood vessels and start causing bleeding. All right. And again, we talked about upper GI versus lower GI, right? Could be either symptom. Again, alarm symptoms again, and dumping syndrome. Who gets dumping syndrome? Someone had their stomach resected, right? That happens in esophageal cancer, and it happens in gastric cancer. And what other cancer? And cancer sometimes, right? If it's invading the stomach, they might have to take out a little piece of the stomach too. All right, so ostomies. So what does a good ostomy look like? Beefy red ostomy, right? You got to make sure the dressing is intact. It's covering just leaving the business end of the ostomy, of the stoma. All right, so the organs. What are the 3 organs of the know? Liver. What else? Pancreas and gallbladder, right? So labs kind of are fluid between them, but we want to know what the different labs are, right? Like lipase for which one? That's the pancreas, right? It's only pancreas. Like even out in, if you have something weird, if someone comes in with a positive lipase, like you got pancreatitis, that's it, right? So it has like a super high troponin. A low troponin can be many things, but a super high troponin can just be it's going to be what? It's your cardiac stuff, right? Or MI usually. All right, so then what else? So we got other labs. There's some other labs we know about. GGT is what? Gallbladder. That's what gallbladder is all about. And alk-phos is everything, but if it's also positive with a bili, that's telling you that it's gallbladder, right? But alk-phos, we're thinking of gallbladder stuff. All right, and then bili. T-bili can be high between all 3, right? Because the T-bili being high can cause what type of pancreatitis, or what cause of pancreatitis would have an elevated T-bili? Gallstone pancreatitis. So that's the overlap there. Scorpion bite is not going to cause T-bili to go up, right?
You're not going to test on scorpion bite?
Maybe. We'll see. All right. So what are the most common causes of pancreatitis and gallbladder stones, for that matter? Or actually, pancreatitis for sure. Alcohol and unknown can be a lot of it, right? Alcohol and obesity is a big cause of those ones, right? Especially gallstones, right? And especially pancreatic acute pancreatitis. As far as chronic pancreatitis, also alcohol, but also acute pancreatitis is the #1 cause of chronic panc. All right, going back to liver. You want to go back to liver? So hepatitis, right? So there's anything that's inflaming the liver, anything that's causing damage to the liver, whether it be drugs or whether it be hepatitis, a viral hepatitis, right? Or ETOH hepatitis, or overdosing on, again, a drug like Tylenol can put you into liver failure, right? If it happens more than 26 weeks, it's chronic liver failure, right? And usually that progresses to what chronic liver failure state? Cirrhosis, right? But if it's less than 26 weeks, it's technically called fulminant liver failure or acute liver failure. Okay, so you talk about teaching for hepatitis, right? Don't overdose on Tylenol. Don't, identify the medications that put them at risk. Yes.
For the, I don't want to say fulminant liver failure,
Mhm.
does only Hep A or can all of them?
Anything can cause fulminant liver failure. And any one of those drugs, any one of those hepatitises, right? A, B, and C all have acute phases, right? Which ones do not have a chronic phase? A is not chronic, right? But B and C are chronic, and those are those are top causes for cirrhosis. What's the other top cause for cirrhosis? Alcohol puts you at risk for cirrhosis, and also obesity, and that's called NASH, right?
I have that. What's that?
It could be something genetic, or it could just be diet related. It's usually diet related.
Anti-food.
All right, so what else? So that's hepatitis. That's like the acute side of what's causing hepatitis and causing liver inflammation and liver damage. And the chronic liver damage is going to lead to cirrhosis, a scarred small liver, right? So we're going to recognize the symptoms. There's like hundreds of symptoms. So it's an easy static question, right? So do they have Gray Turner sign? No, right? There's no Gray Turner sign. What is that associated with? Pancreatitis, right? Do they have, I don't know, I think of another unique symptom. Do they have pain after eating? No, what is that?
That is a bad day, I shake split
What is it? Pain after eating. That's a gastric
Gastric
ulcer,
ulcer?
right? That's PUD, that's gastric ulcer, right? If they have a complication of asthma, is that cirrhosis?
No,
And what is that?
GERD.
That's GERD, right? So we want to recognize those. So my questions have stems or have answer choices from other parts. You can recognize and differentiate. Like, oh, that's not right. That's not cirrhosis, right? So what else? So cirrhosis. There's a lot of symptoms, but there's a lot of complications, right? The biggest complication that's the most deadly is portal hypertension, right? But yes, liver cancer can develop from cirrhosis, right? That's one of the number one causes of liver cancer is cirrhosis of the liver. The portal hypertension is a big one, right? You could probably trace everything back to portal hypertension in some fashion. The portal hypertension puts you at risk for what?
Esophageal varices.
You have variceal. It's a variceal bleed, and the variceal bleed is life-threatening, so you should be able to recognize that. They got hematemesis, that's a problem, right? And they have a variceal bleed. So what's the priority of the variceal bleed?
Give blood.
So you can give blood in the meantime, but we're going to be getting EGD is going to be the immediate fix, right? And if you can't fix it immediately, we're just going to put a tube, a big tampon in there, and hope for the best. And the next day, we'll try another EGD, and they might need to get a what procedure? A shunt of some sort, right? A transjugular intrahepatic portosystemic shunt, or a TIPS, right? A TIPS procedure. TIPS. So yeah, so you get a TIPS procedure to that's also a band-aid as well. It's not going to be curative, but it's going to definitely help with the portal hypertension because that portal circulation is under such pressure. So we're going to get that pressure and put it back into the vasculature. All right, so portal hypertension. In the meantime, before they bleed, how do we prevent it? What meds can we do? I mean, prevention. I mean, they already have cirrhosis. Cirrhosis is irreversible. How do we manage that? How do you prevent that from declining more? Yeah, non-man babes, right? So we're getting non-selective beta blockers, right? Those guys can be given to help vasodilate elsewhere, so the blood will go there instead of the portal circulation. Because as your heart pumps blood to your system, it's going to just go to the GI tract and get reabsorbed or go through the capillaries into the portal circulation, right? So we give these non-man babes or vasodilate elsewhere, so that blood goes there instead of the GI system. Right? But if they start bleeding, what causes someone to start bleeding? An infection is what's doing it. So it's like, why am I giving antibiotics for cirrhosis? That makes no sense. It's because that's what caused the symptom. All right, so variceal bleeds is a problem. And we have, what's that?
What's the drink you drink?
Almond, something they were out of oatmeal. oatmeal, out of the oat milk espresso. But they had to do chocolate almond brie, almond something. Anyways, hepatorenal can be a problem, right? And you want to recognize albumin to be given for 3 complications of liver stuff, right? One of them being hepatorenal. We always treat the underlying cause. That's usually always the right answer, but that's not going to be on the test. That's just a generic thing. But like, what do you specifically can give for hepatorenal is what albumin, and we're going to stop the beta blockers, right? Because that's going to worsen it. Usually, what's causing that renal failure is not getting the blood flow it needs because of the vasodilators with pulmonary hypertension, but also the low albumin. You don't have a lot of albumin to hold on to the fluid. You got albumin for hepatorenal. What else gets albumin?
SBP.
SBP gets albumin, right? So let's put albumin in, right? And ascites gets albumin. Where is it? I lost it. There it is. All right, and we got ascites gets albumin. You give albumin, and SBP, you give albumin, right? That's kind of the linking thing between them, right? And really, those are the 90% of the time you get albumin in the hospital. That's the reason you're getting albumin, because they have some kind of liver issue. Other reasons would be like plasmapheresis. That'd be another reason, but we're not. That's the next test. All right, so you still want to spend some time on cirrhosis, so you want to move on. All right, so hepatic encephalopathy interventions, right? We can talk about protein, we talked about sodium. What about protein? What's the protein recommendation? You're getting high protein diets. Like, well, high protein causes ammonia. So, well, the skeletal muscle breaks down the ammonia. You don't, if you are wasting away, your ammonia is going to get higher. So you want to have that skeletal muscle working. High protein is for all of them, really, but especially to avoid the complications of hepatic encephalopathy, we're giving high protein. All right, liver cancer. What's the test for liver cancer? AFP, right? So alpha fetoprotein. That's also attached to another one, right? Which are the cancers attached to? Gastric cancer. Okay, so SATA for flu-like symptoms, jaundice, liver symptoms. How many SATAs do I have here? 12 so far. All right. What else? You good with labs? We're gonna talk about labs shortly. All right. So AST, ALT. That could be gallbladder. It could be pancreas if the gallbladder caused it. Otherwise, the pancreas has its own thing. What's the own thing? Lipase, right? But liver, got AST, ALT. AST is A for what? Acetaminophen, right? Is it alcohol? I want to think of Tylenol. There you go. Sorry, Tylenol. Sorry. And what's the S? And we got statins, right? That's what's causing your AST to rise. What's causing ALT to rise?
Viral infection.
Right? ALT is viral. Okay, and then T-billy will be elevated with liver and gallbladder. So how do you tell the difference? You got your other gallbladder, you got two other gallbladder labs that'll tell you, oh, I got gallbladder situation.
And ALP.
Alphos and DGT.
You're not going to spell them out this test, right? Like you can just put the abbreviation.
Most likely, yeah. All right, so what else? So we talked about pancreas a little bit, right? The cause, there's a lot of causes, but the most common are your G and your E, right? What are those again? For pancreatitis? What's the cause for I get smashed is the mnemonic for acute panc, but what are the most common is G, which is gallstones, and E is E2H alcohol, right? And that could be an easy static question. It's like what patient says, how did I get this? Like I'm a scorpion, lover, I'm a alcohol lover, I'm a gallstone lover, right? Or I'm female, 40, right? Fertile. What else? So you good with acute pancreatitis? Right? Anything else on acute pancreatitis? Chronic panc is the end result of acute panc, but also you can get there fast. You can skip steps with ETOH. And then we have complications. What are these usually your symptoms too. Complications of chronic panc is you don't have the exocrine function of the pancreas, which is all the enzymes, right? So lack of enzymes means you don't have fat absorption, therefore fat soluble enzymes are in the toilet, literally, right? So we got ADEK problems, right? They got weight loss, they're thin. And they get chronic pain because they start getting little abscesses where the acute pancreatitis was, or they get these chronic, what am I trying to think? Not necrosis, but chronic fluid collections, and then they can turn into abscesses. And then that chronic inflammation puts you at risk for pancreatic cancer. So treatment for chronic panc is to give this pancreatic enzyme replacements. But there was a slide, the chronic panc slide tells the difference between acute panc and chronic panc. So you definitely know the difference, right? So what's your differences? What are some differences right off the bat we just mentioned?
All the malnutrition.
Malnutrition, right? Acute pancreatitis patient, the M and I get smashed is not from malnutrition, right?
With chronic pancreatitis growth, would you like have like the insulin like inefficiencies and stuff here?
Yeah, you get the diabetes, you get the endocrine problems too. Good point. All right. So pancreatic cancer, what are your causes?
Alcohol.
That's going to be alcohol is going to be with all of these, right? Which one is it not? I don't even know, right? But it's alcohol is with all of them. And then chronic panc puts you at risk for pancreatic cancer. The ETOH can cause a chronic panc, but it's like a double, both of those contribute to cancer. All right. So we talked about good outcomes and bad outcomes. Which one's colon cancer? Is that good or bad? That's a good outcome, right? Surveillance. Can you surveil pancreatic cancer? Unless you got lucky and had a headache or had another GI process and got an MRI. Oh, look, we got something else growing over there. That's like the only way you can capture it is by accident, right? Until it starts causing alarm symptoms, right? Not autophagia and dysphagia, but it caused what other symptoms?
Weight loss.
Unintentional weight loss, right? And it might be big enough to start compressing nearby structures, causing abdominal pain. That's basically it. All right, the procedure is the Whipple, right? And we have the other guy too, where we can anastomose the ends. And Whipple is for the head of the pancreas or the tail of the pancreas. That's for the head. So on a gallbladder, what are your gallbladder things? You want to recognize the names, identify if it's a choleldocho, a cholelitho, or a cholecystitis, right? Or an ascending cholangitis. And which one's the worst one? So definitely need to recognize those symptoms, right? I'll make this document, I'll copy this document to the folder and you can highlight it and do whatever you want with it. That way you can say, oh, that's life-threatening. I should know it. I should know that, right? And what tells you have ascending cholangitis versus just regular choleldocho or cholelitho? What is it?
Renal pentad.
You got a pentad. You got two symptoms added to the triad to make it a pentad. And what are those two symptoms that tell you have ascending cholangitis? You get altered, right? And that could be in many different forms. They could be ANO times 2, ANO times 1. They could have a GCS of 7. They could have a CAM-ICU of positive. They could have all these different things that tell you that you are altered in some fashion, right? CAM-ICU is next semester, not this semester. All right, so then the other symptom besides altered is what? It tells you have ascending cholangitis.
Low BP.
You got a low blood pressure, right? So you have to, you can regurgitate that in the test and low BP, right? What is that? What does that low BP look like?
Less than 90.
Less than 90, right? Or MAP less than 65, one of the two. All right, so that's your ascending cholangitis. It adds these two guys right here, and that tells you that, oh, that's worrisome, right? They have all the gallbladder symptoms, right? And they have altered and hypotensive. Then we're changing gears and calling somebody to fix it. Yes.
So for the other 3, it's just the Charcot symptom?
That's Charcot's, yeah, a Charcot's triad. You don't have to know if it's Charcot's or Raynaud's, right? You just have to know that these are the symptoms, right? I'm not going to ask you to spell Raynaud's. Does Raynaud have an L or not? No L. Anyways, so what are your other symptoms though, besides altered hypotension? We know that's a red flag. That should, entice the sphincters. But what are some other symptoms?
Pain,
You got pain. What else?
inflammation,
Fever, right? Pain. That's part of the triad. We're sticking to the triad, right? Here it is, triad right here. You got jaundice, fever, and pain. And we already know about jaundice, right? So jaundice has all those symptoms there, plus fever, right? So we want to try to get things in buckets if you haven't already done so, right? So it's like if I start seeing in my drug guide, oh, it causes pale poops and it causes yellow skin and it causes what, dark urine, right? It's like, well, that's just jaundice. Why don't you just say jaundice, right? And put that in parentheses in case I forgot, right? But it's going to mix them all together and alphabetize them for you. It's like that. Oh, thanks. I love it when it's alphabetical. That didn't help. That didn't help anybody, right? But it's jaundice, right? You got some fever, pain. And where's the pain at? Right upper quadrant, right? All right. So what's the difference between cholecystitis and choledocholithiasis and cholelithiasis?
cystitis is in the gallbladder.
Just the gallbladder, and it could be stone or no stone. It just caught your gallbladder's upset for some reason, right? And it's has what kind of pain? Pain is colicky. It's not burning. It's not radiating to the left arm, right? It can radiate to where? The shoulder, right? So what else? So fever, pain, and you know the difference between the three? You want to go over it? All right, so cholecystitis is just right there, right upper quadrant, pain, fever, jaundice. Okay, and then cholelithiasis. Basically, it's the same symptoms, but you have a stone. And how did you find the stone? Did you palpate it? Did you percuss it? No. All right, you used an ultrasound, right? Ultrasound, CT, MRI, all the things, but ultrasound's the best, right? And then that means that the stone is there in the gallbladder. Once the stone crosses that threshold, just like a vampire, it's going to be becoming what? Stone found in duct, right? And if your stone is found in the duct, how do you fix that? You're still going to see it with an ultrasound, right? Now with ultrasound, you got a CBD oil +7, right? 7 plus. You got your common bile duct is dilated, your CBD, and we can fix with what? ERCP. You can go in there and you can yoink it out. Okay, and ERCP has its own complications. It's just like an endoscopy procedure, the same teaching for EGD, right? Not the same teaching for colonoscopy, because colonoscopy you have to do what? You have to prep for colonoscopy. You have to prep for an EGD or ERCP? No, it's just thoughts and prayers. That's it, right? Which is the high five emoji, which is funny, but anyways. It's like grandma died. But yeah, so you want to do prep for ERCP, same prep for EGD, right? Which is consent, right? And then we're going to get some moderate sedation. But we have some other complications besides the hypotension associated with sedation. What are the other complications of ERCP? Yep. Pink. Acute pink. And just like with the other scopes, they can scope to scopy, and they can poke through the esophagus or the bowel. Okay. And with the colonoscopy, you didn't mention that, but what's the other little asterisk, a little tiny thing you have to do for colonoscopy? Bowel prep, which is not fun. You have to drink 4 liters of Go Lightly. Go Lightly is PEG. Go Lightly is the brand name, so I can't give you brand names. So what's PEG stand for? It's polyethylene glycol. All right, so we got to prep for that. Now we have the mag what? Mag citrate, because mag hydroxide is for what? What's mag hydroxide for? Not for colonoscopy prep. GERD and for PUD. And what does it do for those? So hydroxide is going to bind with what? Hydrogen. And mag is going to cause what? Symptom. What side effect? Diarrhea. Good. All right, so anything else? I think that's it, right? Treatment for gallbladder, we have some other options on the table for a few other meds we can give them. In the meantime, always going to recommend non-pharmacological, like weight loss. I'm not going to recommend alcohol. You're going to reduce alcohol. What else? Any other last minute questions that we didn't cover? This has helped to give an overview.
Yeah.
Okay, or you're like, now I'm more scared. Right?
You should go enjoy Disney.
Mhm.
Don't forget that picture I made her for you, though, right?
A mater.
I want you right next to him. Tell your daughter to do.
Something like
You'll be upside down.
that. Mhm. All right, any last minute things? We'll wrap it up.
What did you think? Is that gonna be uploaded on the